So welcome everyone. Thank you so much for joining today's webinar, Defining and Describing Rural Communities in Comprehensive Cancer Control Planning. My name is Ikra Haji, and I'm part of CADCA's Geographic Health Equity Alliance. The Geographic Health Equity Alliance, or GEA for short, is a CDC-funded national network dedicated to reducing geographic health disparities related to tobacco and cancer. GEA provides free training and support to state tobacco and cancer control programs and their partners on how to reduce health disparities and improve the health of communities across the nation. We encourage you to visit our website, geohealthequity.org, to learn more and subscribe to our monthly newsletter, which will keep you up to date on our latest webinars, resources, and training opportunities. GEA, in partnership with the University of Iowa's Advancing Cancer and Rural Equity Lab, is very excited to present today's webinar, which is the first webinar in our 4-part Rural Inclusion in Comprehensive Cancer Control Planning series. Next slide, please. Thank you. I am sure we are all very familiar with Zoom by now, but I'd like to go over a few housekeeping notes. So all participants are muted by default. So if you have any general comments, please use the chat box. We will have a Q&A portion at the end of the presentation. So for any specific questions you have for our presenter, please use the Q&A box. And tomorrow you will receive a post-webinar email with the recording of the webinar, slides, and registration information for webinar 2 of the series. There will also be a link to a brief evaluation survey, which we kindly ask you to fill out. Letters of attendance are given only upon completion of the evaluation survey. Next slide, please. Now I'd like to introduce our presenter. Dr. Whitney Zahn is an assistant professor at the University of Iowa's Department of Health Management and Policy and is a full member of the Holden Comprehensive Cancer Center. Her research employs health services research, social epidemiological, and spatial methods to address rural cancer disparities across the cancer continuum and to evaluate access to healthcare services. She has a particular interest in reducing cancer disparities among rural minority populations. She leads the university's Advancing Cancer and Rural Equity Lab, and Dr. Zahn also serves on the board of the Iowa Rural Health Association and co-chairs the Cancer Prevention and Control Research Network, Rural Cancer Work Group. Dr. Zahn, I will pass it over to you now.
Thank you, Ikra, and thank you very much for that introduction. And I'm really excited to be here with you all today to discuss something that's very important to all of us, and that is comprehensive cancer control planning, and particularly understanding the importance of looking at rural populations when we do this. And so glad to be here with you, kind of representing my lab, which is the Advancing Cancer and Rural Equity Lab, as Ikra mentioned, or the ACRE lab, kind of tying into that agricultural aspect that's in the Midwest. And this lab is a group of students and myself who focus a lot on rural cancer. And so very excited to be here to discuss, how we can use different data sources that describe rural communities and describe the rural cancer burden in our comprehensive cancer control planning processes. And as I saw in the chat that, there's a lot of people represented here, and I'm grateful for you all being here from, state public health departments, cancer coalitions, academia, rural health associations, et cetera. And so thank you all for being here. So we have a lot to discuss today, and I look forward to this discussion. Just a little bit of the agenda for today. As Ikra mentioned, this is the first in a series of webinars that we focus on, including rural and comprehensive cancer control planning, with today focusing on how do we incorporate rural data into these plans when we talk about describing the rural cancer burden, describing the population within our states or tribal communities, or whatever the context is for our comprehensive cancer control planning processes. And then, to kind of lay the foundation for that, I'm going to provide a little bit of an overview of, where do we see rural cancer disparities broadly throughout the United States, and then discuss, why we should include rural in this process and how we define rural. I think it's really important for us to think about, because it's not an easy. It's a question that those of us in rural health research or rural health in general ask ourselves constantly, because there's so many different definitions, and some of those definitions don't mesh well necessarily with our own when we see an area, thinking that's rural or urban based upon where it is. So there's, kind of the adage is that, when you've seen one rural community, you've seen one rural community. So it's recognizing the diversity within rural and also recognizing how we define it, but also the importance of having concrete definitions for linking to cancer relevant data. And that includes, cancer data on burden screening, relevant health behaviors, but then also other data that are important for discussing comprehensive cancer control planning, like population data, social determinants of health, and workforce information. So that kind of lays the foundation for the discussion today. And here, kind of reiterating this, our objectives for today, and these are the things that I hope that you all can walk away from today, understanding the need for including rural data in comprehensive cancer control plans, to be aware of different definitions of rural at the federal level, then be able to identify rural relevant data on cancer burden and risk factors, as well as other sources of data, and then to be able to integrate these data into your plans. And as Ikra mentioned, this is part of a series. Today, we're going to talk about defining and describing rural communities, then build upon that with how, build partnerships to support rural cancer control. It's important to have those rural voices at the table. I know those of you who are part of comprehensive cancer control programs within your state, some of you may have spoken with, as Ikra mentioned, I co-chair the Rural Cancer Work Group of the Cancer Prevention and Control Research Network, and one of our ongoing studies is trying to see how comprehensive cancer control programs are integrating, including rural voices in their processes. And so thank you for those who have participated in that. We've reached out, we've interviewed a sample of program directors. And so that's something we want to build upon and be able to share, best practices for supporting rural cancer control by having those partnerships and having those people involved also in the plan development process. And then as we think about, both developing the plan and setting those rural focus goals, objectives, and strategies, the third webinar will focus on, best practices for developing those. Yeah, we'll also tie back to some of the data sources we talked about today for ways that we can, identify baseline data and about, data to see our progress to meeting those goals and objectives in implementing those strategies. And then, ways that we can implement those strategies are through evidence-based, comprehensive cancer control kinds of activities. And so the final webinar will focus on that, because it's not solely about developing the plan, but also how can we implement and evaluate the plan? What are some ways that are helpful if we have rural focused goals or objectives or strategies that we can work with those rural partners to integrate those? So that's just setting the stage for this series of webinars, but just wanted to share a little bit of what we're talking about today, and then what we'll be talking about in the future. So just to I know all of you as people in the cancer control space are familiar with a lot of disparities, but I just want to share some key statistics and information so that we're all working from the same place when it comes to the foundation of who our rural communities are, what challenges are they facing when it comes to cancer and accessing healthcare services for cancer. So a couple of things to note is the recognition that upwards of 15 to 20% of our populations are in rural communities. And that includes almost 59 million Americans if we look at that 20% number. And this gets to why we have, we do have some different definitions. So that's why there's that range. But this is not a non-significant number of people. In some states, it's much higher, 60+% of their populations are rural. So it's really important to address those needs because of, how many people do live in rural areas, even though those populations are smaller, they're still, a notable part of our population in the United States. I think another thing that is important to recognize, and I know many of you, depending on the nature of your state, are going to be familiar with this, but we've seen in the most recent numbers that rural communities are actually becoming more and more racial and ethnically diverse, where the most recent estimates from the 2020 census suggest that 24% of rural people are non-white. So I think that's important for us to know. I think sometimes the stereotype is that rural is white, and rural is not a monolith. So it's important to recognize the diversity that exists within rural as well. And it's going to be state dependent. There's varying levels of that, but even in states that are less diverse, there's certainly some diversity within those. That's important for us to consider. When we think about the potential for there to be a higher rural cancer burden, we have to think about some of the demographic and socioeconomic characteristics that are more common in rural, including rural populations being older, often being older and often being poorer than urban populations. And so that creates some unique challenges with having higher risk for cancers or having competing health concerns, and also having more challenges beyond just living further away from cancer care in accessing that care, higher rates of uninsured status, financial burdens with travel to care, all of those things that might create some unique challenges for rural populations. And we see this play out when we look at cancer outcomes. And I put this idea of cancer outcomes to be very broad, to include health behaviors, and I put, for lack of a better term, more prevalent, quote unquote, risky health behaviors. So higher rates of smoking, higher rates of physical inactivity, poor diet that tends to be, more prevalent in rural populations, lower uptake of HPV vaccinations to prevent HPV-associated cancers. And we see this amongst the population as a whole, and we see this, persisting sometimes in those who are cancer survivors, where some of those health behaviors tend to continue to be more common, that that we need to address. And we see this also in higher incidence rates of quote unquote preventable cancers. So those that have opportunities to be prevented with not smoking, or getting an HPV vaccination, or getting colorectal cancer screening, which has primary and secondary prevention opportunities there, with identifying precancerous polyps and removing those, or identifying cancer early through screening. So those are important things to consider. We see some cancers, there's lower screening rates in rural, and ultimately this leads to higher mortality rates for cancer overall, and as for specific cancers. And we also see some challenges with access to primary care practitioners, cancer specialists, NCI designated cancer centers, that can be a barrier to getting the care that's needed. In some studies, and there's some mixed findings with this, that rural populations are then sometimes less likely to receive care that's concordant with recommendations or guidelines. And looking at this a little more specifically, this research is becoming a little bit older. But this is some work my colleagues and I a while back did on cancer incidence trends, and I think I just wanted to share this, because when we look at cancer incidence for lung cancer, colorectal cancer, cervical, HPV-associated broadly, not just cervical, and tobacco-associated cancers, not just lung cancer, we see that there's persistent higher rates over time for each of these specific types of cancers. And we see some places this is widening. So we see this widening for lung cancer as an example, tobacco, relatedly tobacco-associated cancers, colorectal cancer, we see that widening a bit. And we see HPV-associated cancers actually increasing in rural populations over time, whereas the other ones thankfully are decreasing, but they're not decreasing as fast in rural populations. And I share these statistics in part because these are cancers for which those of us involved in comprehensive cancer control planning really have an opportunity to strategize in ways to make a difference. You know, these are ones that can be really impacted by changes in policies, systems, environments, which are really important, obviously, for comprehensive cancer control planning. So I just wanted to share this as a background. I know this is a lot of, I don't want this to be overly, you know, these are all the challenges, the problems with rural communities, because there are so many good things that we'll talk about next webinar, that there are a lot of strengths within rural communities to address these disparities, the collaborative nature of rural communities, the ability to work together, the close-knit nature of rural communities. I think it's really important to recognize too, that while there are these cancer disparities, I think there's really an opportunity to really effectively impact these disparities because of the strengths that lie in rural communities. So I do want to share that as well, but today we'll be focusing a little bit more just on the data aspect. So I wanted to share too about why maybe there this need for, you know, specifically including rural in the comprehensive cancer control planning process, and kind of the impetus for some of this discussions with that I've had with the Geographic Health Equity Alliance and some of my, you know, ongoing research that I've been involved in conjunction with the Cancer Prevention and Control Research Network, is from this report from the National Advisory Committee on Rural Health and Human Services that came out almost 3 years ago. And one of the recommendations from that was for the CDC to require organizations to assess rural-urban cancer mortality rates as part of their plans, and then appropriately develop and implement rural-focused cancer control goals, objectives, or strategies in those specific areas. So regardless of whether this becomes something codified by the CDC or elsewhere, I think this is something that's important for us to consider. And this is something some students and I and some other faculty members did some work on, just to kind of see at a baseline, you know, how many plans have rural in some way, shape, or form within those. And so we did a study last year, or that was published last year, where we looked at the plans that were on the CDC's website as of January 2020. And we found that over 2/3 of plans, you or your predecessors at your respective programs mention rural in some capacity, which is great. So we're glad to see that that's integrated in there to some extent, and we see that, you know, a little less than 1/3 had a rural specific goal, objective, or strategy. So we're glad to see that. We recognize too that, you know, there's opportunities to continue to build upon this rural inclusion, so we can help reduce some of those disparities that we see are more common in those populations. So I also want to just, I guess, to further kind of describe the impetus, or why do we really need to focus on this beyond just this recommendation from this National Advisory Committee, is that there's ways in which both the National Comprehensive Cancer Program priorities and some of the guidance from the CDC self-assessment tool for comprehensive cancer control planning intersect in ways that we can really address those rural disparities. So we can think about the cancer control continuum for primary prevention to survivorship, and how, you know, are there things within rural populations that we really can address within those? That also is true for some of these other areas like policies, systems, environments, as well, but particularly in this idea of health equity, and, you know, health equity being, you know, the need to make sure that everybody has access to care, and has this access to care, has the opportunity to live a healthy life based regardless of where they live, regardless of who they are. And so I think that's something that's really important. We can see how this intersects with some of these pieces within the self-assessment tool, and, you know, and that self-assessment tool's guidance on, you know, key components of a comprehensive cancer control plan. And I have these bolded here: the presentation of data on disease burden. You know, there are opportunities for us to include rural specific data, and then also reduction of cancer disparities, identifying those populations where there's the greatest need. And so we'll focus on those today. Some of these other areas of self-assessment tools we'll focus on in future webinars. So breaking this down further, here are a couple kind of bullet points within each of these that are in the cancer CDC's cancer plan self-assessment tool within presentation of data on disease burden that are really key components that they recommend including. Burden risk factors data from the state cancer registries, demographic data, other types of social and environmental data, and then seeing where there's gaps in data. And I think that's something that's always a challenge with rural cancer data, as I'll talk about more, is sometimes we just don't have the data or the rural population's too small for us to have stable estimates or have sufficient sample size to release data based, without risking the privacy or confidentiality of those who were part of a survey or, were a cancer case within a county or whatever it might be. And then tied to this other aspect from the self-assessment tool, if we're sharing rural specific data, if we're looking at that as part of our comprehensive cancer control planning process, then we're able to identify, okay, are rural populations at greatest risk for certain types of cancers or for being diagnosed at a later stage of cancer, whatever it might be. If we're looking at the types of data we'll discuss today, then we're able to then identify those and then be able to designate those high risk groups for intervention, maybe specific strategies that are targeted towards rural populations or other populations who are experiencing greater risk. And so I think those are important things. And then, as I mentioned, some of these other components of this self-assessment tool we'll discuss in greater detail in the future. So I just want to share a couple of things before we transition to the next part. And these are just some examples of how some states have included rural in their comprehensive cancer control plans in recent years. So you can see Georgia outlining that there are disparities between urban and rural parts of the state, where higher mortality rates were present in the more rural areas of Georgia. The Oregon plan noted, how many of their counties were designated as frontier. They note that they're not how many, I guess, knowing how many counties they have total, but they also have been recognized that, it's not all the same throughout the state. And then recognizing that just how many people live in rural areas in Louisiana and tying that to some of the factors that might be associated with poor cancer outcomes and recognizing that in the state of Louisiana. So those are just some examples of how that's been in there from more the data and population description perspective. So that's kind of just laying the foundation for us today. Before I kind of transition to the next part of our discussion, I do want to talking about defining rural and then some rural specific data sources. So I want to start off with this idea of defining rural, and I'm going to be talking a lot about federal definitions. I share that because that's going to be true for everybody. On this call, these are definitions that are used federally for a lot of reasons, and so they can be, they're going to be true for everybody. But I recognize too that every state, I shouldn't say every state, but some states have their own definitions of rural that they use for a variety of reasons. I've seen that with, I think Oregon has their State Office of Rural Health has, definitions that are used. I've seen in Illinois' Comprehensive Cancer Control Plan that was just recently published that, they pull in a definition that's used by their state primary healthcare association. So recognizing that, there might be some more local definitions that are used, and if you have those, you can discuss amongst your coalition or others as to what's most appropriate. But I think it's really helpful because it's to understand the federal definitions as well. So I'll go ahead and move forward. So when we think about defining rural, there's several kinds of factors that we consider. A lot of times we might think of, okay, a rural area has a small population, or the density of people is smaller, people are more spread out. They're further away from more urban or metropolitan areas, and or maybe people don't really commute to those urban areas for work, Distance plays a role, and those are some factors that play a role in how we define rural. And there's different geographic units that you'll see in some of these federal definitions. County is a very common one that we use, and I think that can be really helpful because, you know, county has some kind of administrative structure in a way that's different than zip codes or census tracts. It tends to be larger. Oftentimes, you know, our local public health departments are at the county level, or maybe sometimes the multi-county level or sub-county level, depending on how big the area is. But I think it's a helpful unit to be used when we think about defining rural. I also wanted to share this diagram that helps us understand the standard, you know, hierarchy of census geographic entities and how they fit within one another. Specifically pointing out, and we all know, of course, that counties are within states, but then census tracts are nested are within counties. So all the census tracts, they don't overlap, you know, they don't spill over into an adjacent county. These are smaller units of typically between 1,500 to 8,000 people within a census tract that they use for, you know, census purposes, but also a lot of data. So that's a smaller unit, but sometimes we might want to use that to get more granular areas if we have the data for that. But that is one that I just want to note as well. So when we think about different definitions, there are several that are used. I just want to highlight, you know, a few of these that are noted here, particularly the county level ones. There is the Rural Urban Continuum codes, RUCC or RUC codes, depending on how you want to say the acronym. And these are county-based codes from the USDA that have a range of values from 1 to 9. 4 to 9 are the non-metropolitan or rural counties. Oftentimes you might hear non-metro or in rural used interchangeably. And these are defined based upon population size and adjacency to metropolitan areas. Another one from the USDA is the Urban Influence Codes, which has a wider range of potential values of 1 to 12, where we see 3 to 12 are the non-metro or rural values. And these are defined, you know, very similarly, but, you know, break down a little bit differently. And the CDC has their urban rural classification scheme for counties, which goes from 1 to 6, and 5 and 6 are the non-metro or rural counties. These are based upon the metropolitan size of the population size of the metropolitan statistical area, which is a way of defining an urban area and kind of the amount of social integration within that. So we see that also in this OMB or Office of Management and Budget definitions. So those are, you know, frequent county measures. I will note, and we'll see this on the next slide too, that while there's some variation within these, if we're doing a simple binary metropolitan, non-metropolitan designation, the counties will be the same within each of those if you're just doing that binary split. But do want to note that. Census tracts have rural urban commuting area codes that can be linked to census tract level data. And I'll note too that, you know, all of these county level measures, you can link that to county level data as well to help understand, okay, is this county rural, and, you know, and what does that cancer screening rate represent, a rural or urban county? So we see, you know, there are these that are broken, that break down further. Also are the RUCA codes, the Rural Urban Continuum area codes, are approximated to what are known as zip code tabulation areas, which are a way to geographically estimate the bounds of a zip code. Because zip codes are a postal designation. You know, as on the previous slide, I had that hierarchy kind of diagram, and that was separate than kind of the county census tract, the middle, that, you know, so zip codes can cut across counties, can cut across states, but that is one that may be used if you have zip code level data. There are also these frontier remote codes, which indicate if, you know, if there's no code, that indicates it's not frontier or remote, but these 1 to 4 indicate, you know, varying levels of remote, frontier, and remoteness. So if you want to get into the more more frontier areas. This is going to be something particularly maybe in more Western states that you might have interest in looking into. But that's another data source for defining rural. So again, this idea of what's non-metropolitan and metropolitan, you can see how that's laid out. Again, this is regardless of the definition used, that this gives us that idea. The counties in gray are those non-metropolitan or rural counties, and the counties in red are those that are metropolitan. So you can see almost all states have non-metropolitan counties rather, but I believe it's Rhode Island, New Jersey, and Delaware that do not have any non-metropolitan counties by this urban definition, or this federal definition rather. But we do see there's significant, actually more non-metropolitan counties than metropolitan counties throughout the country. So I just want to note a couple other things as we go forward. We saw this MSA, or Metropolitan Statistical Area, noted in one of the definitions, but this will come up later and talk about some data sources. How we define this metropolitan statistical area as a core area containing this population nucleus and adjacent communities that have a certain amount, notable socioeconomic integration. So we'll see that come up later on. I just wanted to note that. Increasingly, we see in some of the research, people are using this eligibility for funding from the Federal Office of Rural Health Policy, which kind of combines this idea of non-metropolitan counties, but then recognizing that census tracts within those that might be in areas that have a large geographic size, like 400 square miles in size, and a small population density within these rural or urban commuting area codes of 2 or 3, which are metropolitan in nature. There might be some areas that beyond just the non-metropolitan counties that should be eligible for this funding. So I do want to note, you might see that come up, and that might be helpful to look at a little bit, especially if you're maybe looking into working with communities who may seek this type of funding. I haven't seen really many, if any, funding that's cancer specific, but there's certainly obviously broader public health issues that are important for cancer too, but just wanted to note that. Okay. Another resource I just want to share is this Am I Rural tool, which is from the Rural Health Information Hub that I'll talk about in greater detail in a moment. But I want to share something here just to give you an idea too of recognizing that while that non-metropolitan metropolitan split at the county level is the same everywhere, there can be some nuances, or you might want to find out more information about different places. So I'm going to share that tool here briefly. Switch over here. So hopefully you guys are now seeing a web browser. So if you're not, yes, please let me know. Okay, thank you. And this is a tool from the Rural Health Information Hub. This is linked in the slide set that we'll share later. And you can put in either a town address, a mailing address, a town name, etc., into here, and it'll show you some information. So I'm going to, if I were to type in this rural Illinois, there's actually a town, I'm from Illinois originally, there's a township called rural Illinois. And so it happens to be a rural area. So if we were to type in rural Illinois, you can run this report and it'll tell you some more information. This is in Shelby County about eligibility for, rural health clinic designation, different Federal Office of Rural Health Policy programs, and then provides, information on different rural urban measures, the ones we talked about today, as well as some others, just to give you an idea of what this might correspond to, as well as, shortage area designations, which enables eligible healthcare providers then to bring people in. I think it's the Health Services Corps, which helps provide funding for, that helps do things like reimburse med school or loan repayment programs, other things. But that's getting on a tangent, but I just wanted to share, this tool that might be something that is helpful for you in just trying to get a sense of different areas of your states. So let me switch back over to the slides and make sure I'm not rambling on too much. There's a lot of information to cover here today. So just want to note a few other things, just as some caveats and some important things to consider. As I mentioned, these are sometimes used interchangeably, although there are some nuances. As I mentioned, these are the same if you use the binary categorizations. And a lot of times, this is reiterating some things I mentioned. I guess I got ahead of myself on some of the points I had on these slides. Is that oftentimes county is going to be the most feasible unit to use for planning processes, because there are often data at that level, and there's often that infrastructure to integrate, implement different things. As I noted, some states have created their own definitions, so you might be familiar with those already, or you can contact perhaps your state office of rural health or others for more information to see if your states have their own, because we can see there's some nuances with that. I know in different states I've lived, there's states that counties that have been designated as urban, primarily because they are on the highway between two urban areas and just the commuting patterns, although it might feel more rural. So there's some things that might be more local specific. Some other caveats I just want to note, and this is in no way to kind of just go to negate everything I just said, but this is just some things to note, is that these measures that I've talked about were based upon the 2010 census. So we're realizing, we're 12 years out from that. So we're seeing, there are population dynamics at work over the last 10 years that might make things seem a little different than what these measures reflect. We are seeing also with upcoming definitions of urban and subsequently rural, there's been some changes where the definition of urban in the upcoming in the recently done census and how they're going to use that data going forward is more reflective of households, not population. So this might affect then the definition of rural. There are actually thoughts that this might mean there's going to be more rural communities. And we also recognize that we had our last census impacted by a pandemic. So there's concerns that rural populations as well as minoritized populations, there might be undercounts of those. So again, this is not to negate the things I just shared about the current definitions, but just hopefully to put this in context and to be aware that there may be some in future years, some new definitions coming out. The ones that I shared, most of those were developed in 2013. So I anticipate in 2023 or maybe a little later with some of the pandemic impacts, we'll have some updated definitions. So that might be something just to keep an eye out on as you're working on your comprehensive cancer control plans in the coming years, that there might be some updates to those. So here's what I think what you came for is more on the idea of data, cancer burden screening and cancer relevant behaviors. So I'm going to be sharing some things, and all of you being in the cancer control space, I'm going to be sharing some things that you are likely already familiar with to an extent. I hope it's still useful, and hopefully just the way I just talk about these, I hope that it'll be maybe just thinking about these data in a different way, or recognizing that we can analyze some of these data in a different way than maybe has been done previously. So if these are not new to you, I still hope this is helpful, but I think there'll definitely be some new ones here as well. So I just want to talk through very briefly. Here are some of the things that we'll talk about: cancer burden, cancer screening, and cancer relevant health behaviors that I think are important for us to think about in these planning processes. So I'm just going to talk through a few of these varying levels of depth, because I know at least those first two especially, everybody's going to be very familiar with. But I do want to make sure that we can think about how these can be used in different ways than before. So again, I'm talking about these both in the sense of doing straight up rural urban comparisons, maybe identifying differences between colorectal cancer incidence in rural areas of your state versus urban areas, to allow for the identification of those high-risk populations that were noted in that self-assessment planning tool. But then also, showing ways that we can look at, county level data. Maybe we see that there are lower rates of colorectal cancer screening are more frequently found in rural counties or in a certain part of the state or things like that. And looking at that county specific data then can allow for more geographically targeted cancer burden descriptions or goals, objectives, and strategies. And we'll talk a little bit more about that going forward. But those are the two overarching ways that we're going to be talking about these sources of data, and hopefully that will be helpful. Cancer registry data, I think, is something everybody's probably very, very familiar with. This is, cancer registries will have data on incidence, staging, types of cancers, treatment, we'll have relevant demographic data on age, gender, race, ethnicity, variety, potentially some other elements as well. And registry data are required to be geocoded at the census tract level, but there's variations in the release of that data by those cancer registries. So, and there's going to be, whether that's, getting a specific request to those cancer registries or what they have publicly available on their websites. And there's other resources that will have cancer burden, cancer incidence data that we'll talk about, but that's one that I think, everybody's going to be very familiar with. But I think it's important to recognize, since we do have that geocoding of that data at the census tract level, which also means there's likely going to be a variable that indicates county, for example. You can talk with your registry leaders and staff regarding, the processes of getting, rural incidence for colorectal cancer, lung cancer, et cetera. So you're able to break down that a little bit further. I've looked at a lot of cancer plans, and there are a lot of data on incidence, but I think it is helpful to have, that understanding of, not just the overall incidence within a state or incidence among men and women or across racial ethnic groups, but I think having rural urban specific data can be really helpful as well. Again, this is something I think everybody's familiar with, but just kind of that note that, there can be the, data at the rural urban comparison level, but, I think really talking to your cancer registry leaders and staff can really pinpoint what's going to be specific for your state, what's available publicly. States have different levels of data on their websites, but that can be helpful. Brfss data, everybody, many people are going to be very familiar with this, but I do want to note a couple things. One is that the publicly available data set from the CDC has two variables that allow for rural-urban comparison. So that's something that is new since 2018. So if that's something that you're working with epidemiologist, statistician, or someone within your state public health department to work with that data, that's already in that publicly available data set. Of course, we're talking with your state BRFS coordinator can give you a lot of other analysis options as far as comparing across different areas or using your own state's specific rural-urban designation. There are several cancer relevant variables. Questions that are asked annually about smoking, diet, exercise, if someone's had a past cancer diagnosis, so you can get a little bit a sense of cancer survivors and maybe their health behaviors or other factors that are important. In even numbered years, there are information about different types of cancer screening, colorectal, breast, and cervical. I believe there's some on PSA. There's some optional modules on cancer survivorship, e-cigarettes, HPV vaccination. The HPV vaccination question, I'd direct you to a different source, because that one is looking at people under the age of 50. And so you're going to capture people who maybe weren't recommended for HPV vaccination based upon just how that's the more recent recommendation and some of the other nuances there. But I saw there was a comment about lung cancer screening data, and my understanding, I was at a meeting recently, is that the lung cancer screening has been an optional module over the last few years, but that it's been included as part of the main survey in the version that is out in the field currently. So hopefully that means that in 2023, I think this is usually released in September, there'll be lung cancer screening data for every state. I don't know that definitively. That's what I heard from a very, somebody who knows, but this is something that has an optional module currently. So there are some states for which there is lung cancer screening data, but I think you can also, talk to your coordinator about what data might be available from that perspective. With BRFSS, you are able to add questions. That does cost money, but that's something you can consider if there's like a really important question for your state that you want to look into. But that's just an FYI that lung cancer screening data is hopefully going to be available soon. So the state cancer profiles, I do want to point that out again. This is one I know people are going to be more familiar with. But that has a lot of important information at the county level on demographics, screening and risk factors, incidence and mortality. You can generate maps like the one here on the right, downloadable tables, graphs of trends, etc. It does not have a statewide rural specific, like here's the rural cancer rate, here's the urban cancer rate, but it does have these county level measures, identifying, high mortality counties, and you can see, okay, is this a rural county or urban county, or do these tend to be more rural counties, these higher mortality rates? That can be helpful. So some caveats to note are some county level data are somewhat dated. So they've done some small area estimations on things like cancer screening, but I think those are from small area estimates from like 2008, 2010 BRFSS. So they are a little bit dated. I can talk a little bit more about some other data that's more recently available. And we do see too that, for example, here is the death rate for colorectal cancer in Illinois over a 5-year period. You can see some of these counties, there's too few cases. Under 16, I believe, is the the number in which they suppress the data because for confidentiality purposes, but also for just not being able to generate a statistically stable rate. So we see that sometimes with some things with different measures, but I think this is still a very important source of data that we can point to. CDC Places is a fairly new data set that includes data at the county census tract and places level. And places is, in that sense, is the census is way of saying town or city. There are some cancer relevant estimates in here. So a lot of these are going to be small area or model-based estimates at these geographic levels. So this has prevalence of cancer history. So the percent of people who are cancer survivors, you're able to maybe see that with, state to state variation. It has an interactive map and downloads. One thing I will note is, with some of this cancer screening data estimates here, those are going to be more up to date than those that are found in the state cancer profile. So hopefully that will be helpful for those who are looking at these specific estimates. And also information on cancer relevant health behaviors, smoking, drinking, exercise, etc., that are within that. So you're able to do that, look at that at a more geographically granular level. I'll show that one very quickly. So you're able to, for example, look at, take too long. So things like current smoking. This is an interactive map that you can take a look at, but you can also download data. So you can kind of zoom into different areas and see those different estimates as well. So that's just one resource to point to, but this Places website, you can download all of this for your state and look at this more specifically. Okay. Moving forward, I want to make sure I leave time for questions as well. CDC Wonder is another resource that you all may be well aware of already, but I do want to note that it provides information on public health data, a variety of sources, types of public health data, including deaths by cause, and, which includes cancer. So, you can look at the ICD-10 codes. This range of codes indicates what they call malignant neoplasms or cancers, and you can break that down by a variety of different cancer types. You can do cancer-specific crude, age-adjusted mortality rates by non-metropolitan and metropolitan status. You can, stratify by race, ethnicity, age, gender. You can do trends and combined years analysis, best practices in general. If you're doing like a kind of cross-sectional snapshot, you want to do 5-year estimates combined. That's often used in cancer surveillance. You could do, county-specific mortality rates as well, not just that rural urban designation, but even for 5 years, you might have some suppressed data because they don't want to share, it for the sake of, again, confidentiality, and then also generating stable estimates. I think that can be an issue. This can also generate text files so that you can pull that data, put it into a spreadsheet, make graphs and things like that. Let's see, kind of walk through that, but I want to make sure we have time to address some of the other things. But that is one that I think can be very helpful for both. Just, it's one of the few resources that has the ability to do this rural urban, but also county specific generation of mortality rates. And I think that really ties back to the impetus for including rural plans from that policy report that came out a couple of years ago. One thing you might see, I should note, is when you go to CDC Wonder, you'll see this database that says cancer statistics. And that can be really helpful for getting information at the state level or some other kinds of stratifications, but unfortunately it doesn't have a rural urban kind of way to designate those, but that is there. That's on the cancer incidence side, I should say. But that's something just to note. If you see that, this is going to be something you access more through the underlying cause of death link within CDC Wonder. Another one that I want to note is this, what's called Teen VaxQ, which is an interactive website from the CDC, which can generate estimates of HPV vaccination uptake for non-metropolitan statistical area. That one of the rural measures mentioned within a state. You can see here, this is from California. You can see, the percentage of males and females who have at least one HPV vaccination is a lot lower in the living and non-MSA level. One thing you will run into at the state, state-specific data is there might not be enough data then to generate stable estimates for the being up to date with this vaccination, but it's still, I think, a very useful way to look at this. And you can download this as a spreadsheet in addition to just the bar graph that's shown here. So shifting gears kind of to that, that's just a broad, very quick overview of some of those rural relevant resources for cancer incidence and burden and risk factors and screening and all of those things. But I think it's also important to be familiar with some other data sources when we think about describing rural populations or our populations as a whole, and ways that we can address things more upstream, perhaps. So there's obviously, we want to have goals, objectives, and strategies around increasing screening and reducing incidence and those things. But sometimes to address those things, we need to make sure, people, our poverty rates are improving, or there's more access to healthcare services, there's more primary care providers. And so understanding where we're at with those kinds of things can be helpful for thinking more upstream from the more policy perspective. So with that, I'm going to talk about several other sources of data, population level data, social determinants of health, as we see kind of this very common CDC social determinants of health diagram, education access and quality, healthcare access, neighborhood and built environment, social and community context, and economic stability. And then also workforce. And that kind of ties into this healthcare access, but I think it's important to look at it on its own. Kind of going back again to the Rural Health Information Hub, which is just an excellent resource for many things. I know somebody put that in the chat as well. I think it's a really, really good resource. And it also, in addition to that Am I Rural tool, it has some state-specific information on the rural population within each state, some demographic background information. This is for each state. So you can go to this link here, go to your state. You can know how many rural health clinics are in rural areas in your state, or how many federally qualified health centers are in rural areas or hospitals. There's information on the social determinants of health. There's contact information for your state office of rural health. And so that, that resource is very good. And they also have this Rural Data Explorer, which I think is just a wonderful resource. So I'm going to actually pull that one up quickly and walk through just a couple of things there. So this is the Rural Data Explorer pulled up here. So you can look at a lot of different indicators, demographics, disparities, workforce, etc., social determinants of health, veterans, tribal health. And you can, if I were to pick, as I had up on the previous slide, state of Arizona, and the percent living in poverty, it narrows in on that. You scroll down and it has all the measures, the non-metropolitan or metro designation, the percent living in poverty, and you're able then to download that data, share that data, social media, save the image of the map. So I think it's just a really great resource in that sense. And you can also then look at different years, see how that's changed. If you want to go back to 2010, you can look at how the numbers are there. You can also then just if you want to just look at the non-metro counties, you can click that and it'll just show the non-metro counties. So that, again, this is another great resource from the Rural Health Information Hub that will provide some of that data that you might want to put into your comprehensive cancer control plan to show what your populations are like. Go back to the presentation. County health rankings, again, this is one probably you all are familiar with through just general public health work, but I think it is a really excellent resource for a variety of county level measures that you can see here on the screen. These are the ones that are more cancer relevant, in addition to a lot of social determinants of health types of data. And you're able then to, identify areas where you might want to target different strategies or objectives. So, we have Pennsylvania here. We can see kind of in northern Pennsylvania, which are some of the more rural areas, we see areas that have worse access to exercise opportunities. So a smaller percent of the population has adequate access to location for physical activity. So that might be something where you can intervene to help improve, cancer prevention through exercise. So again, that's one I know a lot of people are familiar with, but I think it's a really good resource to look at for some of these more upstream factors when it comes to cancer prevention and control. The American Community Survey, a continuous survey performed by the U.S. Census Bureau, collecting data on demographics, socioeconomic factors, housing, et cetera, those social determinants of health and population descriptions. There are data available at many of the geographic levels we mentioned today, and you'll want to use the 5-year estimates for these geographic levels because that's needed to have, for them to produce an estimate at that small of a geographic level. Some of these measures are in the county health rankings. So the county health rankings combines a lot of data sources into kind of one single platform, including some American Community Survey data. In some ways, that might be a little easier to work with than the American Community Survey directly. The National Historical Geographic Information System is also another way to get at that American Community Survey data. I think those two options of access are a little bit more user-friendly than directly getting it from the American Community Survey website, but that is, those are all options for some of these data when you want to describe, some of those characteristics of your communities. Another resource I want to know is called the Area Health Resources File, which is from HRSA, the Health Resource and Services Administration. And this has county level data on healthcare professions, facilities, population characteristics, et cetera. Some of this is pulled again from the American Community Surveys and other, in a variety of different sources, the AMA and others. And that enables you to look at the county level at a variety of factors. Their website does have this kind of interactive map that, we can look at, the number of providers per 100,000 as it is here. And you can see this is Colorado. There are fewer providers in Eastern Colorado at the county level. But they have specific data like number of providers within each county. So then you're able to combine these, aggregate these, and to do, a rural urban comparison in addition to, county specific comparisons. So that's a nice feature. You can access the data as this interactive map. I think this only includes some of the health profession data. It doesn't have some of the others, but it's still helpful to kind of see that mapped out. You can download Excel or SAS files or PDFs of some of these. One of the unique caveats, though, is while there is a lot of great information, health professionals, it's not just how many providers are in each county. It's, how many female providers, how many male providers, how many providers at different age groups, if you're wanting to look at, potential shortages in the future based upon potential retirement. There's a lot of data on that, but for whatever reason, there's not data on medical oncologists. So there's radiation oncologists, there's primary care providers, urologists, GI surgeons, a lot of people who are going to be doing cancer-related services, but for whatever reason, that data is not available. So that is a caveat there, but it's still a really great resource to describe, workforce and other things within that. Yeah, that's an unfortunate thing. There's other resources I should note. From CMS, the Center for Medicaid Statistics, and my colleagues and I have looked at some of that. So that's another source I should have threw into here. It's a little more unwieldy to work with, but there's certainly, likely most, if not all, oncologists do bill to Medicare. So there are other sources that it might be accessible there as well that I can have additional conversations with you all. And I with trying to put this into an hour and a half, I wanted to just highlight some of these, but there's certainly some others out there. And also I think looking within your own states, as I'm sure you all continually do in your work, you're going to be able to identify state-specific resources that are available from state public health department colleagues, looking at things that each state has different surveys they're doing or different ways they're collecting data. On the oncology side, you may have licensure or regulatory offices that have data on medical oncology or other sources, other licensure that you might be interested in looking at, or state offices that have, that are focused on health workforce. So those are others you can connect with. Nonprofit organizations, extension offices may also collect data that are unique to your state. Academic partners, different schools of public health, schools of policy, medical schools, all sorts of different schools within universities may have dashboards or other resources that provides data in a unique way beyond the federal sources that I've talked about. I wanted to share the federal sources because it's going to be applicable to everybody here today. But certainly you want to make sure you're using the resources that are specific to your state as well. So the key takeaways here today, we know that rural populations experience notable cancer incidence, mortality disparities, have higher rates of some of those cancer-related health inhibiting types of behaviors. And we really want to make sure that type of data, rural specific data on these different factors and the social determinants of health are integrated into the plans so that we're able to get a full picture of our populations. There's a lot of resources available to look at this, both from just that rural urban comparison, the county level perspective, but also recognizing beyond the data sources shared today, there are going to be local resources that will be really helpful as well. And there's more resources than a lot of time for today. If you have any specific questions, I'm happy to help identify data sources. As I mentioned, came to mind just a moment ago that Medicare would have some of the medical oncologist data perhaps as well. Anyway, just wanted to wrap up with that. Also wanted to acknowledge GIA today, Geographic Health Equity Alliance, for the opportunity to chat with you all today and in the future on some of these important topics around rural cancer. Some of the collaborators on some of the initial study on how is rural included in these plans, and as well as Radhika, who's on, I think I saw that she was on today, who's putting together some resources we'll be able to share later on this summer. And we'll be able to share, some of the slides, obviously, but also putting together some web-based materials with links to some of these sources that we've talked about today, as well as the Cancer Prevention Control Research Network, who I'm continuing to work with on some work around this area of rural inclusion in comprehensive cancer control programming. So with that, I am happy to answer questions that you all may have through the Q&A box. I have my contact information here. Feel free to reach out to me at a later time if new questions come to mind. Thank you all for your attention. I know a lot of these sources may be familiar to you, so I hope I hope this was still a useful experience for you all. And happy to answer any questions that you may have this time. So thank you very much. I did want to go back to some, as you're thinking of potential questions, I did want to go back to some of the comments I saw earlier. Yeah, these are some challenges with collecting rural data. The how is a challenge if we're doing primary data collection. I think as much as you're able to partner with rural communities, especially, we don't want to come from outside and collect data and leave. We want to, partner with those communities, identifying champions within those communities who may have a real interest in cancer, to facilitate if we're wanting to do focus groups or surveys within rural communities or whatever it might be, and also coming back to those communities afterwards and sharing what you found, I think is really important for the how to collect those. This is directed to a comment Jill put in there. I think that can be really important, but it is a challenge. I think the pandemic has made some of us more challenging as we are doing more things in person or going to communities more frequently. Over the past couple of years, we haven't done that. So I think those are important things to make those connections early on, to work with the local hospital, local public health department, and others as well. And Jolene brought up, the small numbers issue is really a challenge. I think that some of that's been tried to been addressed through like the CDC places data, because they do model-based estimates that hopefully help address some of those concerns, because they are doing that. To the statistical approach they're using is addresses that. There's still some limitations, but hopefully that helps a little bit. When we look at rural, racial, ethnic data, that intersection is really important to consider, and we do have that challenge with those data. But I think, hopefully with, we working with your local public health, with your state public health department, your state cancer registry, to see, are there ways that we can combine more years than usual to help get a picture of that? That can be a way to look at that a little bit more, or there's statistical methods that we can use to do model-based estimates or those kinds of things that can be helpful. The lung cancer screening data, hopefully with that new BRFSS question being part of every state's BRFSS in this current year, that in the future that will enable some more ways to measure uptake of lung cancer screening going forward. But happy to answer other questions. I just tried to touch on some things that I maybe didn't address with some of these slides, but can leave some more time for questions if people are thinking.
And Dr. Zahn, I think it's good to note that you did provide your email address on the slide.
Yes,
so if anyone has any questions, is it all right if they contact you directly?
Of course, yeah. I'm happy to answer questions, or if there's anything that you all wanted to share with me that maybe I'm happy to hear that too, or happy to follow up in any way I can. But appreciate everybody taking the time to be here. I hope it was helpful. I hope the future ones can build upon this and thinking more concretely. This is just introducing a bunch of data sources, but I think the other webinars will be some more what's the word I'm looking for, practical, also practically, how do we engage rural partners? How do we think about developing goals, objectives, and strategies, and implementing evidence-based strategies going forward that can really make a difference in some of these numbers that we're seeing here.
Absolutely. And since I don't see any questions, thank you so much for addressing the comments in the chat. And we wanted to thank Dr. Zahn for her presentation, which shared a wealth of knowledge and resources. And we also wanted to thank the webinar attendees for your participation. If we could go to the next slide, please.
Oh, of course, yeah.
Thank you so much. So stay tuned for information on the next webinars in this series. The post-webinar email that will go out this week will have a registration link for webinar number 2, which is on July 13th. And as a reminder, we kindly ask for you to complete the evaluation survey that will be included in that email. And so thank you again for joining us, and we hope you have a wonderful rest of your day.